Hello students, welcome to the fourth video lecture for Healthcare Ethics, Fall 2020. This lecture covers a chapter by Michael Yeo and Anne Morehouse titled Beneficence. It was published in Concepts and Cases in Nursing Ethics, which was edited by Yeo and Morehouse and a couple other people, and was printed by Broadview Press in 2010. So this week's lecture concerns the ethical principle of beneficence. But before we get there, we're going to do a bit of review. So the four key principles that we are focusing on in this course and that define the approach called Principalism in healthcare ethics, those four key principles that make up Principalism are autonomy, beneficence, non-maleficence, and justice. So far, we've focused our attention on autonomy. We learned the four senses of autonomy as defined by Bruce Miller, which are autonomy as free action, autonomy as authenticity, autonomy as effective deliberation, and autonomy as moral reflection. So here is where, if we were in a classroom, I would stop and I would write each of these on the blackboard and I would ask you to explain each one to me. Since we're not in a classroom, I'll have to tell you, and I'm going to have to trust that you guys are writing it down and getting it, and also trust that if you're not getting it, that you will ask me about it on Thursday. So autonomy as free action, as you guys wrote in your worksheets, is the ability of a patient to make a decision free from coercion, free from undue influence, to make their own decision. Autonomy as authenticity is the ability of someone, presumably a patient, to make a decision that is true to themselves, to who they are, to their character. Autonomy as effective deliberation refers to the decision-making process itself. Do you weigh the consequences and benefits well? Are you able to process the information necessary to make the decision? And autonomy as moral reflection means asking the big picture questions like, what is the purpose of life? What is the meaning of this? Should I really be doing this? Okay? So, four senses of autonomy. Autonomy as free action, autonomy as authenticity, autonomy as effective deliberation, and autonomy as moral reflection. And as you may have gathered from this, autonomy is all about making healthcare decisions. So in order to understand autonomy, we studied a bunch of different aspects of medical decision making and strategies for preserving patient autonomy in different decision-making situations. Perhaps the most important of these strategies is informed consent. So informed consent is a process of shared decision-making that supports patient-centered medicine. It is, rather importantly, a conversation. So the idea is that the healthcare provider and the patient discuss together the potential treatment and the patient's concerns about it, leaving room for the patient to ask questions and making sure that the patient understands what's going on. One useful way that the article we read last week suggests to check for patient understanding was the teach-back method, which is exactly what it sounds like. So using the teach-back method, the provider asks the patient to repeat back to them what they heard to make sure they got it. So you guys are making informed consent brochures for your group project. And we're going to be talking about them in the group meetings on Monday. But it's worth pointing out that you're not making informed consent forms. So informed consent is a form of legal documentation that requires signatures on forms, but it is, for our sense, in an ethical context about a conversation and exchange of information. And so the informational brochures that you guys are making, we are imagining would be part of that exchange of information. So they're brochures that would help a patient understand what they are consenting to. You can think of them as supplements to the informed consent conversation, and you can use the checklist in the Ripley article that we read last week to help you figure out what you need to put into your brochure. So that checklist appears on page 1641 of the Improving the Informed Consent Conversation article written by Ripley et al. And like the informed consent conversation, your brochure will focus on a specific procedure, and it should cover the benefits, risks, and alternatives to that procedure. Okay, so those are 3 key things that you guys want to try to hit in your brochures, and there are 3 key things that are part of the informed consent conversation. That is, it has to include the benefits, the risks, and the alternatives of a specific procedure as it relates to a specific patient. Okay, so we also talked in the past couple weeks about competence and surrogates. So in order for a patient to make an autonomous healthcare decision, they need to be competent. They need to be able to process all that information in the informed consent conversation. According to Applebaum, who we read last week, the patient needs to be able to communicate a choice, to understand relevant information, to appreciate the situation and its consequences, and to reason about treatment options. So this should sound a little bit like those 4 senses of authenticity to you, but these are the criteria that are necessary for a patient to be a competent decision maker. Okay? They need to be able to communicate a choice, to understand the relevant information, to appreciate the situation and its consequences, and to reason about treatment options. They also need to be a legal adult, which is what that question on the worksheet from last week was all about. Okay. So it's also important to remember that capacity and incapacity to make medical decisions is decision specific. So a patient might be able to make some decisions and not others. It's also not a status-based judgment. So just because a patient has been diagnosed as schizophrenic doesn't mean that they are just completely unable to make medical decisions, right? A status, like a diagnosis, does not determine competence. Instead, you have to evaluate each decision on a case-by-case basis. And in practice, we are more careful with evaluating the patient's capacity when the decision that they're making is a big one, when it's something like a life or death decision. Another important thing to remember is that we generally assume that all adult patients are competent to make their own decisions until it is proven otherwise. Okay. But what happens if a patient is incompetent, if they lack decision-making capacity? So let's just say, for simplicity's sake, that the patient is in a coma. Who then will be making their medical decisions? So this is where surrogates come in. The point of surrogates, the reason they exist, is to preserve patient autonomy even when the patient is not there. So there are 5 kinds of surrogates, as you guys wrote in your worksheets from 2 weeks ago. And they are generally defined by how they get appointed. So there are 2 kinds of patient-designated surrogates. There are formally designated patient-designated surrogates, and there are informally designated patient-designated surrogates. And the distinction between those 2 is that one is a more formal legal process, and one is just the patient telling their healthcare provider that they want so-and-so to be their surrogate. Pretty simple. Those 2 are very similar. They both indicate the patient has decided before they became incapacitated, before they slipped into a coma, who they want making their medical decisions for them. Court-designated surrogates are very similar, but just appointed by the court. Physician-designated surrogates are appointed by the physician according to a list that is in state law. And that list says X, Y, and Z person should be the surrogate in the situation where the patient has not designated the surrogate and the court has not designated the surrogate. Okay? So in some situations, the patient hasn't decided, there's no court influence, and the physician has to decide. And the last kind of surrogate is the surrogate for unbefriended patients. And that's when there's no one there on that list. And then the physician themselves or other healthcare workers have to end up acting as the patient, as the surrogate for the patient. Okay, so the 5 kinds of surrogates are formally designated patient-designated surrogates, informally designated patient-designated surrogates, court-designated surrogates, physician-designated surrogates, and surrogates for unbefriended patients. And perhaps more important than remembering the different types is remembering how surrogates are supposed to make decisions. So this shows up at the end of Pope's article on pages 1077 through 78. And there are 3 standards and they go in order. Okay, so if you're writing anything down, this would be the part to write down from Pope's article. So if you're a surrogate, if someone appoints you to make their medical decisions while they're in a coma, the things you have to go by are, first, the subjective standard, executing the patient's wishes. So if your friend who's in a coma told you before they ended up in a coma how they wanted something to happen, then you have to do what they said. That's executing their wishes, and that's the subjective standard. If they didn't tell you anything, if you don't have any written record and they didn't express their wishes to you in any manner that you can recall, then you have to go with substituted judgment. So you do what you think the patient would have wanted. You do what you think your friend would have wanted when they're in a coma. And it's not what you want, and it's not what you think might be best. It's what you think the patient would have done in that circumstance. And then last, if they haven't expressed their wishes and you don't know them well enough to figure out what they would have wanted, then you do best interest. So only as a last resort do you do what you think is in the best interest of the patient as far as health is concerned. So best interest is supposed to be just an objective standard where you're like, what would be best for their health? And you don't think about what they would have done or what you would have done or what your family members might have done or anything like that. It's just what would be best for their health. Okay? But you only get to that one if you haven't got the other 2. And that's basically it for autonomy, or at least that's it for what we've studied this far. Autonomy will show up in relation to all of the other terms that we will discuss throughout the course, because it is the biggest motivating principle behind most of healthcare ethics, and in some senses behind all of Western philosophy. Autonomy is certainly the motivating principle behind capitalism, and it's a major influence in the traditions of thought that have developed the university and intellectual knowledge and what you guys are studying in this course, healthcare ethics. So at any rate, today's lecture does not focus on autonomy. It focuses on the second principle on our list, beneficence. So if autonomy is all about making medical decisions, beneficence is about the people who work in healthcare, the people who execute those decisions for the patients once they are made. So beneficence is about healthcare workers, nurses, doctors, PAs, CNAs, EMTs, social workers, everyone who interacts with patients in a medical setting. And beneficence is their ethical obligation, the ethical obligation on the part of healthcare workers to do good. So if you guys remember all the way back to the first lecture, you will recall that I defined beneficence through its Latin roots, and that definition shows up again in this week's reading. So beneficence is made up of two Latin words, bene, for good, and ficere, which is the verb to do. This week's reading actually lists the first person form of that verb, which is facio, I do. At any rate, beneficence, at its root, simply means to do good. Bene ficere. In the words of this week's reading, and this is on the very first page, beneficence as an ideal or principle of conduct requires us to act in a way that benefits others. So the reading we did for this week, as I said at the beginning, is a chapter on beneficence written by Michael Yeo and Anne Morehouse for a textbook on nursing ethics. It also happens to be a book that was published in Canada. Like we talked about before, in terms of critical reading skills, it's important to know the context of the readings that we are doing. And so don't just imagine that these things came from Blackboard, right? I got them from somewhere too and put them up there. So this comes out of a Canadian textbook. And the publication information helps explain why the reading is all about nurses and why there are a couple references to Canada in the text. So there are certainly a lot of differences between single-payer socialized medicine in Canada and insurance-driven medical capitalism in the United States. But what's important for us in the context of this class is that the ethical principle of beneficence is operative in both systems. Okay, so if the definition of beneficence is doing good, what does that mean in practice? Our authors for this week, Yeo and Morehouse, answer this question with a series of dichotomies. So they get their point across in this article primarily through contrasts. If we were in the classroom, I would write these out on the board, but since they're not, I'm going to have to ask you to write them down in your notebook. So the first big dichotomy in the article is desire versus duty. So this is the idea that it's all well and good when you want to help people and the things that you have to do to help them are nice and easy, but what about when they're hard? What about when you don't want to do the thing? So Yeo and Morehouse write on pages 105 through 106, quote, although desiring to do what will benefit others is a big part of beneficence, beneficence must be rooted in something else besides, or in addition to desire. So it's not enough to just want to help people. There needs to be something more to ground this principle of doing good. When the nurse finds satisfaction or gratification in caring for the patient, beneficence is easy. The situation is different when there is some degree of conflict between the nurse's own desires or self-concern and what is required to benefit the patient. So here they're setting up a conflict between the nurse's own desires or self-concern and the requirements or duty of benefiting the patient. So they give an example here, and I'll read it out for you. So they write, perhaps the nurse would rather not attend to the homeless man, dirty, lice-ridden, and reeking of the street, brought into the emergency. Meeting his needs may be very unpleasant. Perhaps the nurse would prefer not to care for the person with an infectious disease. Even with precautions, there is some element of personal risk in the procedure, and a mistake would have very grave consequences. Perhaps the nurse really does not want to work overtime to cover for colleagues with the flu. But, they continue, beneficence enjoins the nurse to attend to the homeless man, to draw the blood sample, or to work overtime. These acts of caring are required as a matter of duty. So that's what they mean in the binary between desire and duty. One might not want to do these things, but beneficence requires us to. So these are examples of duties that beneficence might require you to perform against your desire. On the other hand, they write, nurses have historically been exploited. Nurses have been forced into working long hours for low wages in bad conditions in the name of beneficence. So the question that they pose is how to balance these things. It's not always easy to see what the good action is that one's duty requires one to do. So they ask on page 107, how much sacrifice, effort, and striving does duty require of us? How do we know? What is the duty? To do good. So they introduce another dichotomy here to help explain this, and that is the distinction between caring for others and caring for oneself. So a good example here, and it also shows up above, is the question of dealing with communicable disease. So in the passage I read above, this appears as a fear of drawing a blood sample from a patient with an infectious disease. It also shows up a bit later in the article on page 109, if you want to open your text and turn there. And it shows up in a way that we can connect to recent events concerning the COVID-19 pandemic. So the authors state that, quote, when they care for persons with communicable disease, nurses should be provided with infection control equipment. If that aid is not available, they can refuse to work until they are guaranteed the safest possible conditions. So, nurses, according to our authors, according to the ethical principle of beneficence that they articulate, can strike when they are not provided with infection control equipment. So you guys might remember last spring when the pandemic began, there were shortages of such infection control equipment, which we now call by the name of personal protective equipment, or PPE. And in fact, there were, in New York, a number of nursing strikes demanding more PPE, more infection control equipment. So the question here that arises in these situations is one of balance. How great a duty to beneficence is there in the situation of a global pandemic? Are healthcare workers ethically obligated to labor under dangerous conditions? The nurses who struck argued that the hospital system was ethically obligated to provide them with better working conditions so that they could care for the sick, that is, so that they could perform beneficence while taking on a lower risk. They were trying to balance self-care with care for others. So our authors argue in this article that beneficence does not mean that healthcare providers need to be heroes, despite all the signs that you see about how we love our healthcare heroes. That's not quite what beneficence means. It's not a duty to act in a heroic manner. Instead, it's a duty to balance self-care with care for others. So Yeo and Morehouse also mention burnout, which is an idea that we might discuss again later in this course. Burnout is a thing that can happen when the balance tips too far in the direction of duty and healthcare workers don't exercise enough care. So when people try to be heroes or when employers demand too much of their employees, what actually ends up happening is that outcomes suffer. So they write on page 108, fatigue and stress are not only harmful to nurses concerned, but also increase the risk of injuries, errors, and burnout. So working a 30-hour shift might be heroic, and it might in fact seem beneficent, especially in the situation of covering for colleagues who are sick with the flu, as in their example, but it might also produce bad outcomes for patients. Which brings us to our next dichotomy. So if the first dichotomy that shows up in this article is desire versus duty, the second is good intentions versus good outcomes. And you guys will note at the very beginning of the article, they give us a proverb that the road to hell is paved with good intentions, right? So good intentions are not quite enough for beneficence. It's not enough just to choose to be good. You also need to know how to do good. That is, to have the knowledge that supplements your duty. So nursing care must be supplemented by nursing knowledge. Beneficence requires the ability to do good, that is, the ability to produce good outcomes for patients, as well as the intention to do good. So to articulate this idea, our authors return to the idea of caring about versus caring for, which is another one of their fond dichotomies, which shows up on page 105 and 110. So the example they give is that a mother might care about their sick child immensely, but not have the knowledge to care for them when they are ill. And that a nurse in this situation might have the knowledge to care for the child. And ideally, one would both care about one's patients in the sense of wishing them well and care for them in the sense of making them better. Okay? So their point there is simply that it's not enough to just do one's duty, but one must also have the knowledge in order to do it well. In order to be beneficent, in order to do good, you have to be able to produce good. So a couple other key terms that show up in this article that we have seen before, and that you'll have to deal with in your worksheet, at least one of them. So fiduciary relationship shows up on 106, right? and they use this to talk about the relationship of trust and caring as being a beneficent relationship. So back to that idea of duty, right? Fiduciary is someone who is entrusted, is in a relationship of trust with another. They also talk about a caring relationship on 110, which you might compare to the idea of a fiduciary relationship. They are similar, but not quite the same. Early in the article, they set up a distinction between beneficence and non-maleficence, which we will return to next week. But here, they do something really cool, where they use the Greek word pharmakon to help us understand that distinction. So a pharmakon, or pharmakos, is the Greek root for the word pharmacy or pharmacology. If you want to go get a degree in pharmacology and become a pharmacist, you are learning about pharmakons. And the word in Greek simply means drug. And just like our modern English word drug, it can mean a poison. When we talk about illicit drugs or date rape drugs, that is a sort of bad connotation to the word drug. But drug can also mean a cure, right? In the sense that antibiotics are drugs, or Tylenol is a drug that one buys at the drugstore, right? So the word pharmakon means at the same time poison and remedy. And they use it in a sense to allow us to understand that sometimes the good things that we do, in the sense of beneficence, like giving medications, can also cause harm, right? So you need to balance the desire to do good and the acts of doing good with the prohibition against doing harm, which we'll discuss in more detail next week. Okay, they also ask the question on pages 111 through 110, what is health? And that's a big question, and it might be a useful one to think about in terms of this course, but I'm directing your attention to it here in case you happen to be in a group that is writing about electroconvulsive therapy for your brochure, because you might note that ECT, electroconvulsive therapy, shows up here as an example of a particularly controversial treatment. So there are two examples of controversial treatments, are ECT and abortion, right? Okay, so just a thing to think about if you're writing about that. They also talk about another one of our key terms that's going to show up on your worksheet for this week, which is paternalism. Their way of understanding paternalism is thinking about, and in terms of beneficence, is thinking about whose standards determine what good should be done, right? So not just how do you figure out what good should be done, but who decides what that good is in the first place. So autonomy comes back in here. They write on page 113 that one of the most profound changes in contemporary healthcare has been a shift in the locus of decision-making from health professionals to patients. So remember, as I said earlier in the video, that autonomy is all about decision-making, and in particular, autonomy is about patients making their own decisions, right? So we can think about patients making decisions in this sense as exemplary of autonomy, and healthcare professionals making decisions as exemplary of paternalism, right? In specific, healthcare professionals making decisions for the patient's good against the patient's wishes is what paternalism means. So it's not just being really mean and making decisions against what the patient wants, but making decisions that you think are for the best, that are for the patient's good, right? So we can see how it's connected to beneficence here. And so for our authors today, paternalism arises in the conflict between beneficence and autonomy. So in some ways, beneficence seems like it should go just fine with autonomy, right? Do good and do what the patient wants. But What happens if doing the best for the patient, doing good, is actually not what the patient wants at all? So the example they give is on the bottom of 113, the nurse may be ambivalent about helping a patient with heart disease who needs assistance to smoke. So imagine that you're in that situation, that you have a patient who maybe not even heart disease, but has emphysema, right? And is in really bad shape, and they need your help in order to smoke cigarettes. So they're asking you, can you help me light my cigarette? Can you help me hold my cigarette? But you know, as their healthcare provider, that that cigarette is the thing that's making them sick. It's the thing that's killing them. You might rightly be ambivalent about whether or not you should support the patient's autonomous decision to smoke another cigarette. So you can see how that conflict might arise between paternalism, that is doing what you think is best for the patient, and autonomy, that is allowing the patient to make their own decisions. So at the very end of this article, there's a nice line about this where the authors write, unchecked, the nurse's commendable desire to do good can easily slide into paternalism, right? And they say that paternalism is not necessarily forbidden by healthcare ethics, but it is generally frowned upon, okay? So, and generally in our course, paternalism is a bad word. So, and what we're interested in is thinking about how to balance these things. They also talk about who benefits from beneficence. The question is it just the patient, or is it the patient's family, or is it the society? And this is about the connection between beneficence and justice, which we'll discuss in a couple weeks when we get to justice. Guys, you can also skip that case at the end. So the legal standard of mature minor, which they're talking about, doesn't exist in the United States. It's not our concern. And there were actually a bunch more cases in this chapter, but we're not reading any of them for this week. We cut them out of the photocopy, so you can just skip to the conclusion, which is on the next page in the photocopy. So don't read page 117, but do read the conclusion of the article. The conclusion provides a nice summary, and it returns to this question of paternalism, which shows up on your worksheet, so it's pretty useful to read. Okay? And that's it for this week. And also, before I go, my sincerest apologies if you have not received your worksheet back from last week. I had a bit of a rough weekend and I didn't finish grading them, but I will be returning your worksheets with the subsequent one before we meet this Thursday. Okay? So, and I look forward to talking to you on Monday about your projects. And don't forget that the worksheet which accompanies this lecture is due on Friday, September 25th. Okay? If you have any questions or concerns, be sure to write them down and send me an email or bring them to our Q&A session on Thursday. All right, take care.